Welcome to your first day in anesthesia. I hope you're going to have a very good time on your rotation and your time spent with us. Your first day in the OR can be quite intimidating. There's a lot of equipment, new people, everybody's in different clothing. If you've never seen an anesthetic before or seen any of the equipment, it can be a little overwhelming. This video will introduce you to the process of anesthesia and the equipment that you will see and use. The first part of anesthesia is starting the IV. Don't want to lose that IV. Now we put on monitors. You'll see pulse oximeter, ECG, and blood pressure cuff. Notice those numbers starting to appear on the screen. This patient get 100% for saturation. Next up, we pre-oxygenate the patient and induce with our medications. Notice the doctor checking her IV to make sure that we have a running line so the medications actually reach our patient. Once the patient is asleep, we have to support the airway, hold the mask tightly, and back mask ventilate before we intubate. Notice the 3 fingers under the jaw and then the tight grip on the mask as we squeeze that to have a tight seal and then squeeze that back to make the chest move up and down. You'll also have noticed the APL valve. We'll talk more about that later. When the patient is ready, we proceed to intubate. We can use a variety of laryngoscopes, in this case the standard MAC plate for direct laryngoscopy. Extend the head, slide down the base of the tongue, find the epiglottis, and then gently insert the tube. If you use a stylet comes out right after you go into the larynx, and the tube then gets advanced further. Once the patient is intubated, we'll remove the laryngoscope, attach the tube back to the breathing circuit, and confirm that we have entitled CO2. And there it is, our beautiful entitled CO2 curve, confirming that we are in the correct place. And that is the end of the anesthesia induction. We will now switch the patient to the ventilator and move to the maintenance phase of anesthesia. As you can see, there are many parts to providing this anesthetic. Some basic equipment that you will see will be airway equipment, including masks that you need to size appropriately. These 3 sizes, small adult, usually this one is appropriate for an average sized woman and this one for an average sized man. You can try them on to see if they fit. Oropharyngeal airways to help us with back mask ventilation. Again, try to size appropriately to your patient. The green one is generally good for an adult-sized female, and the yellow for an adult-sized male, the red one for a much larger male. You will see laryngeal masks. There are a huge variety of laryngeal masks on the market, all with different characteristics and purposes. The main purpose is a supraglottic device that will assist in ventilation without instrumenting the trachea. Direct laryngoscopy. Again, there is a multitude of blades in different sizes. This is our standard Mac blade, this is the straight Miller blade, and this is the McCoy scope with a handle that lifts this little lever that can improve your view on laryngoscopy. We have video laryngoscopy. The standard glide scope, the McGrath, or the King are ones that you will see on your rotation. In all of the hospitals in Calgary, this is our standard top drawer. So whichever hospital you go to, this is what you will see in your anesthetic cart. In the top left corner, we have our beta blockers. In the back right corner, we have our uppers. We have ephedrine, phenylephrine, and epinephrine. In the middle here, we have anti-nauseants. We have haloperidol, dexamethasone, metoclopramide, and ondansetron. Here are our muscle relaxants. We have rocuronium and succinylcholine. Here are our anticholinergics. We have atropine and glycopyrrolate. There are some drugs that don't really belong to a category that are scattered. We have nitroglycerin, diphenhydramine, lidocaine, toradol, tranexamic acid, our propofol and antibiotics, and here are neostigmine for reversal. Try to familiarize yourself with these drugs before coming on rotation. There are important drugs for us in anesthesia that we use regularly. The other drugs that you will see, of course, are volatile agents, sevoflurane and dalflurane. This is what we use to keep our patients asleep. Once the patient is asleep, we need to monitor them. So we have to make sure that they're stable during the anesthetic and also asleep. So what does that look like? The standard monitors that you will see on the top screen here, you have the heart rate either represented by ECG or from the oximeter with plethysmography. You have your O2 sat at 97%. You have a blood pressure, systolic, diastolic, and mean. In some patients, you will have entropy, which is integrated EEG. You might have your patient temperature. You might have your neuromuscular NMT monitor looking at your Trano 4. So those would be pretty standard monitors. Now, the anesthesia machine and ventilator. This gets a little bit technical, so if it's a bit overwhelming in the beginning, don't worry too much about it. I'm just giving this as some background information for those who want to do a little bit of wider technical reading. The purpose of the anesthetic machine is to bring oxygen and volatile agent to the patient. There is an oxygen source. There's then a flow meter to control the flow of the oxygen. There's a vaporizer that allows contact between the anesthetic vapor and the breathing gases and the correct concentration. You then have a breathing circuit that takes the mix of vapor and oxygen and air to the patient, and a scavenging system that vents waste gases from the room so that we are not all breathing anesthetic gases. So what does that look like in real life? So our oxygen source, there's usually a piped source. White is oxygen, blue is nitrous, the white and black is air, and the yellow is suction. And this is in Canada as the usual color coding. There will also be an oxygen cylinder, which you can get your anesthesiologist to show you. The oxygen flow meter, that can be either a manual meter or an electronic one on our more modern machines. That will show us what our oxygen flow is and the percentage of oxygen that we're giving. And in this patient, this is also the area where we would do our anesthetic vapor concentration. The breathing circuit that you most commonly will see is a circle system. What that means is that fresh gas comes into this circle that keeps going around and around and around and around. So you have a small amount of fresh gas going in to an already established volume of gas that then goes to the patient. The patient exhales the gas. On the exhaled side, there's usually a pop-off valve, which is this APL valve, and there's a bag, which you've seen before. The bag is there so we can actually manually ventilate the patient. It acts as a reservoir, and a spontaneously breathing patient gives us an indicator of whether the patient is breathing. Then there is the CO2 absorber, which you can see here. This absorbs the CO2 from the exhaled gas. And so all that's left in there is nitrogen, some oxygen, because your exhaled breath has still got about 18% oxygen or more if you've been breathing higher concentrations oxygen, and your volatile agent. That goes back into the inspiratory limb, and the fresh gas flow just supplements that. So however much you've lost through your pop-off or you've used up on the patient side, like oxygen, you have to supplement with your fresh gas to provide an adequate volume of inspiratory gas, and then the cycle completes. You exhale, absorb the CO2, add an appropriate amount of fresh gas, inhale, and exhale. So the important components here is to know about the APL valve, CO2, the bag, and the inspiratory and expiratory limbs. That goes to the patient here. As I said, this is really only for those people who are really interested in the technical aspects. These are not essential parts to know coming into your rotation. The APL valve you will see used because that's what we use when we ventilate the patient to decide how much pressure to have in the system. And when a patient is breathing spontaneously, we have that at 0. When we want to have some pressure built up into the system so we can ventilate and squeeze those lungs, we will usually have that up to about 15 or 20, but not higher. On the ventilator, there's usually a few settings available to you. There's the manual spontaneous for patients who are breathing by themselves or where we are manually ventilating. And then we have these options, which you can ask your attending about more. The pressure support is for spontaneously breathing patients. That just requires a bit of additional support from the ventilator. And then there's 2 main modules, pressure controlled and volume controlled. Volume controlled, we set the volume. And then there's a variety of pressures up until usually a max that can be generated in the lung, depending on the compliance of the lung. On pressure-controlled ventilator, we set the pressure, and then depending on the compliance of the lung, variable tidal volumes will be delivered. So anesthesia. This is what it will look like on the ventilator once you've set it. You have your tidal volume, respiratory rate, a PEEP, an IE ratio, how much oxygen you've got going, and what your Pmax is. And that in essence is what a general anesthetic looks like. Of course, we do more than that. We also have spinals and epidurals in our armamentarium that you will see done. And we do a variety of peripheral nerve blocks, which you hopefully will also see on your rotation. I hope you will have a wonderful rotation in anesthesia. I think it's the best specialty. We have an interaction of pharmacology, physiology, anatomy. We get to spend time with patients at their most vulnerable and hopefully give them a fantastic experience with good pain control. Have fun on your rotation. See you soon in the OR.